Hello and welcome to this module on understanding treatment options in inflammatory bowel disease, brought to you courtesy the Crohn's and Colitis Foundation. I am Dr. Manpreet Kaur. I'm the Medical Director of the Inflammatory Bowel Disease Center at the Baylor College of Medicine in Houston, Texas. And it's my pleasure to join you today. Here are my disclosures. And I wanted to start out by outlining some of the objectives for this activity. We will review some of the similarities and differences between the two main inflammatory bowel disorders, Crohn's disease and ulcerative colitis, review the risks and benefits associated with treatment modalities available for these disorders, what are the impacts of staying adherent to these treatments, and how these diseases can affect quality of life, and what are some tips and strategies that can help you in your interactions with your healthcare teams that can improve your treatment decision making. Inflammatory bowel diseases are predominantly Crohn's disease and ulcerative colitis, but instead of considering them as two distinct conditions, they're really along a spectrum. At one end of the spectrum is Crohn's disease. Now, this is a condition that can involve any part of the GI tract from the mouth all the way down to the rectum. It tends to be patchy, and it tends to involve the entire thickness of the GI tract. Now, as a result of this, two things happen. Because it involves the entire thickness of the GI tract, ulcers that start on the inside of the bowel wall can burrow through the entire thickness and lead to either small tears, which then lead to abscesses or small collections of pus, or can create tunnels or fistulae, which are little tunnel-like communications between loops of bowel, or scarring or strictures. The other really unusual aspect of Crohn's disease is because it's patchy in involvement. So a segment that's inflamed may be severely inflamed, and then a really long segment of the bowel will be completely healthy. So the symptoms one experiences as a result of Crohn's disease are not always representative of the severity of inflammation. So folks may have really severe inflammation and no real symptoms until they go on to develop complications from Crohn's disease. Or they may have a lot of symptoms because they have scarring but no real active inflammation. And that causes a lot of bloating and abdominal pain, but most of the active inflammation has sort of burnt itself out. And that's an important idiosyncrasy about Crohn's disease to understand that as a patient, it's very, very important to recognize that frustrating as it sounds, your symptoms are not always an accurate indicator of the extent and severity of inflammation in Crohn's disease. So if there's one thing I can help you take home today as a patient of Crohn's disease, I would say that that's probably one of the most important points. Ulcerative colitis tends to be a little more predictable. As the name implies, it's restricted to the colon and it presents as ulcers in the colon. These ulcers are superficial. They start out in the rectum and then progress more upstream. So it almost always presents as bloody diarrhea. And here the pattern of symptoms tends to be fairly predictable to the extent and severity of inflammation. And of course, in both Crohn's disease and ulcerative colitis, there are extra intestinal manifestations, which is just a fancy word to describe symptoms of the inflammation outside of the GI tract. So it could be your eyes, it could be the joints, such as painful swollen joints, or the skin, sometimes the liver, etc. So your physician will probably ask you questions about, have you had red, painful, itchy eyes? Do you ever get red, swollen, painful joints or stiffness in your joints? Do you ever have any skin rashes or purple painful nodules on your skin, etc.? So what are our treatment goals? Well, of course, as a patient, it's very, very important for you to know that it is important that we control your symptoms. But as I mentioned before, symptom control may not always mean that we've controlled inflammation. So that is why we would, as physicians, would often want to check blood tests, stool tests, or get some colonoscopies, or in some cases imaging studies, to confirm that in addition to controlling your symptoms, we're also doing a good job of healing inflammation. Because studies now show that controlling symptoms while there's still active inflammation, it doesn't really improve long-term likelihood of avoiding surgery, hospitalizations, etc. And of course, when I first see patients, I always ask them what among symptoms bothers them the most, because that helps me understand what has been the most disruptive in terms of their symptoms at having sort of decreased their quality of life. And together then we can set some reasonable expectations of what they can expect. In 3 months, I tell patients, in 2 weeks, I expect you to no longer have blood in your stool. In X weeks, I expect you will no longer have to worry about where the restrooms are, or looking for the restroom when you're in a new environment. And in X weeks, you can expect to be able to make a 4-hour drive, etc. So that's essentially how we approach treatment. But so in addition to controlling symptoms, improving quality of life, your physician will incorporate some testing, blood and stool testing, as well as some endoscopy and radiology testing to ensure that we're meeting these objective markers that show us that inflammation too has healed. So what are some of these factors that help control inflammation in IBD? And you'll see, as I'm sure those of you that know other folks with IBD, no two patients are alike. You may come across patients in support groups. Some have more severe course, whereas others tend to have relatively mild course. Why is that? Well, because there are several different factors that impact the overall nature of disease. So this slide sort of breaks it down into 3 different categories. One would be at the level of the individual patient. So I would add to that a few things. So, the age at which someone is diagnosed, so that would be the middle column, that would be the disease-related factors. The age at which someone is diagnosed, whether or not there's family history of inflammatory bowel disease, that would go into what the genotype is. How aggressive their disease is. Did they need surgery right after they were diagnosed? Do they have other features of the disease that suggests a more aggressive course? And did they go a long time from the time they were diagnosed before they got the right kind of treatment that has been shown to to sort of alter disease progression? The disease-related factors. And then, we all know that that there are certain things that you as patients can do that can improve your overall ability to manage this disease better. So a simple one is to not smoke, especially if you have Crohn's disease. Cigarette smoking has been shown to have a significantly adverse impact on the natural history of Crohn's disease. So if you have Crohn's disease and you're a smoker, you're more likely to have a complicated disease course, and you're much less likely to respond to therapies as a smoker with Crohn's disease. And it's also been well established that that chronic illnesses, especially diagnosed during young adulthood or as teenagers, are of course associated. They do take a significant emotional toll. So if we as physicians do not recognize the mental health impact of these illnesses, then I think we are doing a disservice to patients. So what you as a patient can do is be a better advocate for yourself, and make sure you're discussing with your provider if you have some component of underlying anxiety about your symptoms. I consider it PTSD when my patients have recovered from a severe illness, and then every time they eat something that doesn't agree with them and they get some cramping pain or maybe a couple of loose stools and it terrifies them, I reassure them and I tell them what you're experiencing is essentially PTSD, and that's okay. So it's very important, both as patients, to recognize the emotional toll that a chronic illness can have on you, and as providers, for us to as physicians, to have an open mind and to probe about some of the mental health issues in the setting of these chronic illnesses, because that goes a long way in establishing that open channel of communication. And of course, a healthy nutrition, taking a regular multivitamin, eating a healthy balanced diet, avoiding excess processed carbohydrates, focusing on a balanced nutrition with a lot of plant-based foods and whole grains, etc. And then of course the last one are the therapy-based factors. So making sure that whatever medications you're on are optimized. If you have failed previous therapies, you're on the right dose, which of course is really your physician's job, not you as a patient. And now with the drug level monitoring becoming more widely available, as physicians, it's easier for us to ensure that whichever medication you're on is being optimized at the right dose and at the right interval, based on the dose response and half-life. So as you can see, really the devil is truly in the detail, and no two patients are alike. So that's why in our clinic we really do have a multidisciplinary approach with a dietitian. We have a wonderful psychologist who works with our patients, and we've had great success in getting that sort of heads together approach in managing our some of our more complicated patients. So now let's switch gears and talk a little bit about what are the available treatment options. We'll cover everything from over-the-counter to prescription therapies, some complementary therapies, and talk briefly about surgical options. So let's start with what over-the-counter medications are available. So I really quite simply think of these as just temporizing measures, not really anything that would be used long-term as a sole therapy. I always ask my patients when I see them about how often they're using antidiarrheals, whether it's Imodium or Lomotil. That helps me understand the frequency and the severity of their diarrhea and urgency. It is safe to take on an occasional or an as-needed basis, but you must make sure you're volunteering this information to your physician. If they're not asking you, you must include that in your medication list, because it will help your doctor understand your symptom burden. Because diarrhea with 8 bowel movements a day, if you're taking 4 pills of Imodium, is not the same as 8 bowel movements a day without any Imodium. So it's very important that your physician understands all the medications that you're taking. So if you're not being asked about over-the-counter medications, please make sure you're volunteering that information. In the setting of IBD, Tylenol or acetaminophen is your safest option for managing any occasional aches and pains and fever. Avoid all NSAIDs. Those are your ibuprofen, Motrin, Aleve, Advil, etc., because those can worsen GI symptoms. Moving on to prescription medication, these are the main categories of prescription medication. We'll review each one of these. So almost all patients with IBD have had their brush with antibiotics. There's a role for antibiotics. We use them for treatment of an enteric infection like C. diff. For IBD itself, we often use it in combination with whatever therapy you're on for treatment of IBD related complications like perianal abscesses or infections in the setting of Crohn's disease or pouchitis, and of course C. diff, as it's becoming more and more prevalent. Of course, it's important to be vigilant about C. diff whenever you have diarrhea. Another time to be vigilant is with dental procedures. If you're getting any antibiotics, let your dentist know that you have IBD. If you have a skin infection and you're being put on antibiotics, avoid the dreaded clindamycin, which a lot of urgent care, emergency room, primary care physicians may recommend, because it is an antibiotic that does increase risk of C. diff infection. Or at the very least, let your gastroenterologist know if you develop diarrhea after you've taken antibiotics for a non-GI procedure. So the aminosalicylates, these are used for treatment of ulcerative colitis. They really don't have a role in Crohn's disease, so you really shouldn't be prescribed a whole lot of these. If you have Crohn's disease, there's still some physicians that may be using them, but the data for using them in the setting of Crohn's disease are really not the best. So most physicians should not be, well, we really should not be using them for Crohn's disease. So these are oral medications used in the treatment of ulcerative colitis. To put it quite simply, they work by coating the inside of the colon and just calming inflammation. The medication may be time released, or it may be released by activation by the bacteria in the colon. This medicine does not really get absorbed into the bloodstream to any significant degree. So most of the time it's quite well tolerated. Now, a few folks may develop a hypersensitivity reaction. So they may experience worsening diarrhea. Usually if it's going to happen, it'll happen within the first few days of starting the medication, where you'll have worsening diarrhea, in which case you must stop the medication and let your physician know. And they would almost always recognize it as an allergic or a hypersensitivity reaction. These are the names of the formulations that are available and FDA approved in the US. There are some that are available as enemas, that's the Rowasa, and in a suppository form, that's Canasa. These work quite well for folks that have inflammation in the rectum that can give rise to a lot of urgency and frequency. The frustrating part about it is, I'm not sure why, but these can be quite expensive if they're not formulary with your individual insurance. But with copay assistance, GoodRx is a good source. the copay can become affordable, but it remains a challenge for quite a few patients. But there's no evidence from existing studies that suggest one formulation is better than the other. So really go with one that's tier 1 with your payer, except if you're a woman of childbearing age, then you really should not be on azolfidine. You should be on any one of the others. But if Lialda is expensive, then you need to ask your pharmacist, present them with that list and ask them to go over whatever's on tier 1 formulary for your insurance on this list, and pick one that is available, because that's the one that will be a more affordable alternative. And if you're a woman of childbearing age and your insurance wants you to be on azolfidine, have your physician write a letter appealing that, because there's no reason they can mandate that. That would be an easy appeal to overturn that decision. Corticosteroids. Now, this is a medication that's easily available, inexpensive. You can get it at your neighborhood pharmacy. Tiny white pills, they look harmless, and everybody loves them because you take them and you start feeling better almost immediately. But we all underestimate how harmful they can be. So first, the good part, which I just went over. They're inexpensive, easily available, they work quite well, and they are very effective at inducing short-term remission in both ulcerative colitis and Crohn's disease. But the risks, the list of adverse effects is a very, very long one. The topmost on that list is the risk of infections, especially now that we are and have been in the midst of a pandemic. There have been data that show that corticosteroids, more than any other medication in the setting of IBD, increases risk of severe COVID and death from COVID. And COVID aside, corticosteroids are the most significant risk factor for increased risk of infections in patients with IBD. And other things that they do, of course, they can have a significant impact on sleep pattern, mood swings, weight gain, increase in blood glucose levels, and a premature cataracts, bone loss, impaired wound healing. I mean, the list just goes on and on. So I always teach my residents and fellows, and I always tell patients, two things need to happen every time you start steroids. One, you need to have a conversation about how long you will be on them, or in other words, how quickly you can come off of them. And number two, what happens if after this course of steroids your symptoms recur? So there needs to be an exit strategy. Steroids must always be a bridge to something more definitive. So there always needs to be another plan to escalate your maintenance therapy. In case you need another course of steroids, here's what we're going to do. Or maybe this is it, because you're needing steroids to keep this from happening again. Here's what we're going to do with regards to your maintenance therapy. So here are the formulations that are available. Steroids can be given in the oral form, which is Entocort, Uceris, and prednisone. Entocort and Uceris, presumably not as much systemic exposure, but don't let that fool you. These medications are also associated with significant systemic harmful effects. IV formulations are Medrol, Solumedrol, and then the steroid enemas come as Cort enemas, and the steroid foam enemas, Cortifoam. So immune modulators. Immune modulators are essentially oral medications or methotrexate, which can also be an injectable. So immune modulators are essentially thiopurines or methotrexate, of which thiopurines, you may recognize it as azathioprine, Imuran, 6-mercaptopurine. Those are different names for it. or methotrexate, which maybe 5-10 years ago we would use it as just by itself. Nowadays we almost always use these medications in combination with an injectable medicine to keep you from making antibodies to the biologic medication. And these medicines work by decreasing your ability to generate antibodies. So of course they do increase risk of certain infections. The big ones are mostly viral infections, and the most widely used immune modulators are azathioprine or 6-mercaptopurine. Before starting those, your doctors will want to do a blood test to make sure you have the right type of enzymes to process these medications, because a very, very small percentage of the US Caucasian population is lacking the enzymes. They haven't received the allele from either their mom or their dad. So if those patients receive the regular dose of the medicine, they will absolutely drop their white blood cell count, which can be life-threatening. A smaller number of about 8 to 10% of folks only need half the dose, because at the regular dose their white count will come down. So that's why your physician will check your blood test to make sure you don't fall within that less than 1% of the population that cannot take this medicine, or if you need to take half the dose of the medicine, because otherwise you run the risk of dropping your white count. If you have the normal enzyme levels, you can get the regular dose, but still need to have blood testing done every 3 months to make sure you're tolerating the medication well, with a check of your liver tests and your blood counts every 3 months or so, for the duration of the time that you're on the medication. For the most part, we use these within the first year of being on biologic medications to decrease the likelihood of making antibodies to the biologic medication. So these are the different names: azathioprine and 6-mercaptopurine. Methotrexate can be given both orally and injection, not to be given for women of childbearing age. Cyclosporin and tacrolimus, not used a lot, certainly not to the same degree as azathioprine and 6-mercaptopurine, and also not used for women of childbearing age, because these are not safe during pregnancy. Okay, so now let's switch gears to biologics. So biologics, we call them biologics because these are made from living cells. So these are antibodies directed against specific proteins or chemicals that are perpetuating inflammation. So because these are proteins, they run the risk of triggering an antibody response, because our bodies may recognize them as something that needs to be eliminated, and as a result the body may generate an antibody to the medication or trigger an infusion reaction or an allergic type reaction to the medication. That's why for the first few months these biologics are often combined with an immune modulator to decrease the likelihood of anti-drug antibody formation. So let's review these in a little more detail. These are the biologics that are currently available. Broadly speaking, there are 3 categories. Anti-TNFs, these are antibodies to tumor necrosis factor alpha, which is a chemical that promotes inflammation. These are a combination of an IV infusion, that is infliximab or Remicade, or injections, which is adalimumab or Humira, certolizumab or Cimzia, golimumab or Simponi. And then there are the anti-adhesion molecules, that's Entyvio or vedolizumab. So that is a biologic that decreases the ability of cells that cause inflammation from reaching the GI tract. And then there's a biologic called ustekinumab or Stelara That is an antibody directed against two cytokines, IL-12 and 23. Though most of its effect in IBD comes from blocking IL-23. So again, two categories are directed against chemicals that are promoting inflammation. That's anti-TNFs, and then the anti-IL-23 and 12. And then one category works by decreasing the ability of cells that are causing inflammation from reaching the GI tract. Those are the anti-adhesion molecules. And these medicines are a combination of IV infusions, that's Entyvio and Remicade, or injections, that's Humira, Cimzia, Simponi, and Stelara. For Stelara, in case you're wondering, the first dose only is an IV infusion, then it's an injection at home every 2 months. With the exception of Stelara, most other biologics tend to trigger some antibody formation. So for the first few months, we usually combine these with an immune modulator to decrease antibody formation. And that is not something that needs to be maintained long term. The immune modulator can be stopped after the first year or so. Some of you may be familiar with biosimilars. So what are these? Well, a biosimilar is a biologic medication that is similar to an already approved biologic therapy, and the FDA has deemed it to be equivalent in terms of efficacy and safety. So because these are biologic medications, we don't call them generics. So we call them a biosimilar because they're made from living cells. No two batches are identical. So we truly cannot call them a generic. So the medication Remicade is infliximab that was made by Janssen and was the first infliximab to be approved. That's why infliximab is called the originator drug. And Inflectra is infliximab made by a different company. Renflexis is infliximab made by yet another company, and Avsola is yet another form of infliximab made by a third company. And those are the three biosimilars to infliximab that are currently available in the US. So what the FDA has determined based on studies is that these molecules are equivalent in terms of efficacy and safety to infliximab. So it is safe to switch someone who's on infliximab to one of these biosimilars, but what they have not approved them for is bioequivalent. In other words, the switch cannot happen without approval from your physician. But in reality, what most of us as physicians are discovering is that if we decline to authorize the switch, that for the most part gets denied, and then you appeal it, and then the appeal gets denied. So it's really not as fair a fight as it's made to seem on paper. Fortunately, though, most of my patients that have switched to biosimilar, in our experience, have done quite well. So over the last few years, there are some oral small molecule compounds that have been approved for treatment of ulcerative colitis. So what are small molecules? Just as the name implies, unlike biologics, which are large molecules, these are smaller molecules that are broken down in the GI tract and absorbed into the bloodstream through the intestines. And the ones that are currently approved are tofacitinib, known as Xeljanz, and ozanimod, known as Zeposia, both for the treatment of moderate to severe ulcerative colitis. These are oral medications. They have a fairly rapid onset of action to the point where they are both positioned as steroid-sparing alternatives. And because they are not made from living cells, they don't run the risk of generating any antibodies, so you can start and stop them as needed without worrying about developing resistance to these medications. And these medications work essentially by suppressing the activity of T cells. So they do increase risk of certain infections, mostly viral infections, and can be associated with some nausea, headaches, etc. So let's talk a little bit more about these small molecules. Bottom line, patient selection is key. Not everyone is a good candidate, but some patients will do very well with these medications. So I want to talk a little bit about pregnancy. Neither one of these medications has been studied during pregnancy. So obviously both are probably to be avoided in women that plan to get pregnant in the near future, because we really don't know much about how safe these are, and pregnancy category has not been assigned by the US FDA. Xeljanz or tofacitinib has been associated with increased risk of blood clots in the legs, as well as blood clots in the lungs, especially in individuals over the age of 50. It's probably best avoided in those that have risk factors for any cardiac disease or prior history of blood clots. It is also associated with increased risk of viral infections. Ozanimod or Zeposia, also associated with increased risk of viral infections. More about that in a minute. Specifically, Ozanimod has been associated with increased risk of slowing the heart rate down with heart blocks and slow heart rhythms. It should be avoided in patients that have had inflammation in the eyes, because it can cause swelling of the optic nerve. Both of these medications do increase risk of viral infections, so certain vaccines should be updated. The vaccines for shingles, the only one that's currently FDA approved is the Shingrix vaccine. It's not a live vaccine. The varicella vaccine for chickenpox, if needed, your physician can check your titers, because everyone gets the varicella vaccine during childhood, so you may or may not need it. If you don't have enough antibodies, then you'll need a booster. And of course, the COVID vaccination is recommended before starting either one of these medications. So, bottom line, it's important to understand the risk of these therapies. These are safe and effective therapies. How they work, who they will work best with, has to be kept in the context of individual variations, prior treatment response, history of allergies, intolerances, and your own individual medical history. Children, of course, require special considerations. We need more clinical trials to address efficacy and treatment approaches, because right now we just extrapolate what we know about adults to children. Pregnancy, of course, requires special consideration, and some of the newer medications were lacking data during pregnancy, so best to avoid those. Let your physician know if you're planning on conceiving, because that will determine your choice of therapies at the time of your consultation. Now, there may be a time where surgery will be required, and it doesn't necessarily indicate failure of therapy. It may be what's necessary. Oftentimes, that's the case when you've developed a disease-related complication, such as stricturing, fistula, or abscesses. And surgery is what's the best possible choice to conserve bowel, alleviate symptoms, and that's when you want to be at a center that has done a lot of these surgeries, a high volume place, a center that offers a multidisciplinary approach, where you know that your colorectal surgeon will be able to work closely with your gastroenterologist. Let's not forget the critical role of nutrition. Diet is the food that you eat on a daily basis. Nutrition is how your body uses those nutrients from your diet. At our clinic, we work very closely with our dietitian that does an intake and an assessment for almost all of our patients, so they can have a tailored plan that they can adhere to on an ongoing basis, and that has improved patient satisfaction with their overall treatment plan considerably. So if your physician's office doesn't offer this, I encourage you to seek someone outside of your gastroenterologist's clinic that will help you get a better sense of control and avoid creating a diet that may be needlessly restrictive in the setting of your disease. Broadly speaking, these are some good nutritional choices. A plant-based diet that incorporates whole grains and healthy fats. Things to avoid would be excessively sugary foods and foods with artificial sweeteners, excessive caffeine. Those are more likely to trigger symptoms. It has been noted anecdotally that in the setting of a flare, some patients may be sensitive to dairy. Some. I say that with a word of caution because excessive dairy avoidance may restrict your intake of vitamin D and calcium, which is required because patients with IBD tend to have low levels of calcium and vitamin D. So if you find that you are restricting dairy, you must start taking additional supplements of calcium and vitamin D. It is always a good idea to start a daily multivitamin as well. And I want to spend just a few minutes talking about clinical trials. These are critical in expanding our understanding of therapies. Most clinical trials are very ethically designed and are a big part of our treatment at our IBD center at Baylor. So how these trials work is that you have about a 60 to 75% chance for most trials, the way the placebo and treatment arms are designed. It's usually either a 3:1 or a 4:1 chance of getting the active treatment versus placebo. So anywhere from 60 to 75% chance of getting medication versus placebo. And then after a certain time interval, which is usually anywhere from 8 to 10 weeks, if patients are not responding, and then they have the option of going into what's called open label extension. What that means is 8 to 10 weeks into the clinical trial, if you're not getting better, and then the sponsor looks and checks and sees that if you're not getting better and it's because you got the placebo, then you're guaranteed to get the active medication. You can find out more at the Crohn's and Colitis Foundation's website, as well as clinicaltrials.gov. And of course, talk to your physician about what trials they have on site. Of course, treatment strategies in IBD are evolving. They need to be they need to be personalized to your specific disease behavior and characteristics. And therapy plans need to be personalized with serial monitoring and adjustments to tweak things along and get you the best outcomes individualized to you, and no two patients are alike. That really is the way of the future. What you can do as a patient is stick with the plan. So what can we do to help you get there? Well, adherence is complex and it's multifactorial. What you can do as a patient is knowledge is power. So ask questions. There are several factors that contribute to inability to take medications. We understand that. but we want to help you as physicians. So if your medication is inconvenient, if the way it's dosed, if your infusion center doesn't offer weekend hours and it's hard for you to take time off from work, you need to let your physician know that. If the cost is prohibitive, if reimbursement is a problem, you need to let your physician know that. There may be copay assistance programs you don't know about that your doctor's office can help you with. If your disease is severe and you're having difficulty communicating that with your physician, you need to be able to find ways to communicate. Either the challenge is that you're not being a lot of times I find that patients tend to undermine their symptoms. They're too stoic and don't want to really admit to how ill they are. So don't do that. When you're in your doctor's office, the 15-20 minutes you're there, that's not the time to be stoic. That's not the time to downplay how ill you truly are. And sometimes it helps to write things down before your visit so you can read them off rather than having to recall everything from memory in the 15 minutes you're there. And ask questions. Do not hesitate to ask questions, because these are all things that have been shown to improve shared decision making. So let's talk a little bit about what is shared decision making. Quite simply, it's a process where patients are actively engaged and informed about treatment options. And when patients have a say in their treatment plan, it increases not just their satisfaction with the plan, their confidence in the treatment choice, but they're also more likely to stick with the treatment plan. So I think that there are no downsides to a shared treatment decision making. And as physicians, there's nothing better than that for us. We want better outcomes for you. So if we can get you on board, there is nothing better for us. So ask all the questions. The Crohn's and Colitis Foundation has several tools on its website, such as the symptom tracker that can help you put your symptoms in perspective, so not everything is a blur when you're in your doctor's office. I encourage you to check out the website and use these tools to help you just assimilate all your symptoms and consolidate your questions for those 15-20 minutes that you have during your consultation. And of course, your communication preference may evolve with time as your relationship with your physician evolves, and as your experience with your illness evolves and your understanding of IBD evolves. So I think, and that's okay. So you may have more questions at the very beginning, and then you may not as time goes along. Knowledge is usually what informs those changes. So once again, I encourage you to go to the Crohn's and Colitis Foundation's website and review the multitude of patient education tools that are available, and you will find them quite informative. These are some tips on how to engage in shared decision making, open and honest communication, and make notes. It always helps, and bring someone along, especially if it's going to be a heavy, involved discussion, or if you're feeling too overwhelmed and you're too ill, too miserable to have a heavy discussion. Bring someone along, have them take notes, and recognize sometimes, ask for another visit. If you feel overwhelmed, say, it's okay. I tell patients, I'm not expecting you to make a decision. Go home, sleep on it. Come back and see me again in 1 week or 2 weeks. So recognize there is more than one right way to do things. And of course, I can't say this enough. Don't be afraid to ask for clarification. Don't be afraid to ask to spend more time, and don't be afraid to ask for another opinion. As a physician, we are never offended by any of these questions. I repeat, we are never offended by any of these requests. These are some of the tools that you can find on the Crohn's and Colitis Foundation's website. I encourage you to spend some time reviewing them. You will find them incredibly informative and very, very empowering. So understand your IBD, know what the goals of your treatment are, and participate in shared decision making. It will make you a more empowered patient. It will make you a better partner in your care, and your physician will be much more grateful for that engagement. I want to thank the Crohn's and Colitis Foundation for this opportunity to share my time with you, and I hope you found this activity useful. And I encourage you to access the Foundation's website at the URL provided. You will find a wealth of knowledge and information. And I thank you for your time today.